Welcome back to Chapter 2 of Diabetes Mellitus. I am Jess. I'm your friendly co-host of this particular class on this particular topic. So, the last we spoke, we were talking about other types of diabetes. So I'm going to share my screen and then we will continue on with our talk. So here are some different manifestations. How do we know? How do we know if a person has diabetes? Are there some different signs and symptoms that we can look for? Yes. And these are it. So when a person who is a type 1 diabetic starts having clinical manifestations, here's what you're going to see. You're going to see polyuria, so they're peeing a lot. You're going to see polydipsia, they're really thirsty. And you're going to see polyphagia, and they're really hungry. Here's why. So remember, with type 1 diabetics, they don't have any insulin at all. So there's no gas stations to get the gas from the storage tank to the cells. So the cells are always sending out distress signals. So what happens is they get really hungry because their cells are hungry, because their cells aren't getting enough sugar and they're relying on anaerobic metabolism, otherwise known as the citric acid cycle, back to AMP. Okay, so that does not mean that digestion stops. So they're taking in all of this food, it's getting digested, and the blood glucose is entering the bloodstream. It just doesn't have anywhere to go after that. So this extra blood glucose that's in the bloodstream makes really thick blood. And that triggers the thirst response. The other thing is with this really thick blood and being really thirsty, because there's this extra blood sugar that's in the system, the kidneys will try and eliminate it as well. So between the extra thirstiness and the extra blood sugar, you're going to have extra peeing. So that's kind of that relationship. So people their cells are starving for sugar, which increases the person's appetite. The person's eating all the time, but they're digesting it and the blood sugar is going into the bloodstream. They have no way of using it. So that extra blood sugar in the bloodstream creates excessive thirst because the blood is extra thick and it's too thick to be moving around the right way. And the kidneys are trying to help out by eliminating extra blood sugar. That's the relationship of these three, very cyclical. Also, because there's no insulin to be able to move that blood sugar out, you'll have weight loss, you'll have weakness, you'll have fatigue, and you'll have ketoacidosis, which means that you'll have ketone bodies and that whole citric acid cycle. That's the only way that your client's body is able to survive, is through that anaerobic metabolism, because there's no sugar to use. So that ketoacidosis is causing weight loss. There's no energy because there's no sugar being moved around. There's extreme fatigue because there's no sugar being moved around. And then what will happen also is this ketoacidosis creates a huge amount of byproducts in the blood, which can actually affect the brain chemistry too. BT dubs, your brain does not store sugar and it runs on sugar. So with your brain not having any storage of sugar and your brain running on sugar, if you have no insulin, your brain is just starved and you're going to get really out of it. So in addition to weakness and fatigue, you may have people slip into diabetic coma. They may have levels of consciousness change because that brain only runs on sugar. It doesn't use anything else. And without having sugar, it don't run. Type 2 diabetic clinical manifestations are a little bit less specific. You may see some of those polydipsia, polyuria, polyphagia symptoms of type 1. You will also probably see these people are really tired. They will have recurrent infections that are really hard to get rid of. And that is associated with their immune system not functioning very well. They will have recurrent vaginal yeast or candida infection. We all have yeast living. Okay, don't get grossed out. We all have yeast living on our body. We have it living in our oral mucosa. People with vaginas have it living there too. And I'm going to pause my recording for right now. Hold on. Okay, continuing on, back to diabetes clinical manifestations. So what will happen with prolonged wound healing and visual problems is all of that extra blood sugar that's circulating around that's not getting moved into the cells to be able to use for energy. It travels around like little pieces of, anybody ever use like a sugar scrub to help like exfoliate their body? Or if you've traveled and you can see like the rock candy suckers at the different roadside attractions, sugar has the same physical structure regardless of the size of the crystal. So whether it's itty bitty like blood sugar or whether it's ginormous on a stick for the roadside attraction. So with wound healing, what happens is those capillary beds that are in charge of healing the wound up are getting beat up by all of the different sharp edges on the sugar. As the retinas in the eyes also get beat up by all the fine little corners of the sugar as well. So anything that's got a capillary bed gets really beat up by extra blood sugar, whether it's type 2 or type 1, just so that you're aware. So in diagnostic studies, there's 3 different slides of this, and then I'm going to end this chapter. So first of all, there is the hemoglobin A1C. Hemoglobin A1C is not the same as hemoglobin. So if you have a hemoglobin A1C level of like 8, that is not good. Of course, if you have a hemoglobin of 8, that's also not good. But like if you had a hemoglobin A1C of 12, that's awful. And hemoglobin of 12 is like really cool. So make sure that if you're looking at hemoglobin HGB or HGB A1C, HGB A1C is different than hemoglobin, just to let you know. So if the person has a hemoglobin A1C of 6.5 or higher, these are all and/ors. You don't have to have all 4 of these. These are just like 4 options. They can be used in combination or standalone. A fasting plasma glucose level of greater than 126. There's a 2-hour oral glucose tolerance test greater than 200. That's used a lot with people who have gestational diabetes, but it's also used with people who are pre-diabetic or who we have some risk factors for pre-diabetes and we're just checking things out. And then there's either like the classic symptoms of hyperglycemia or a hyperglycemic crisis, or a random like glucose check like from the lab of greater than 200. So any one of these may be used as a diagnostic study for diabetes. Hemoglobin A1C is kind of like the gold star test for type 2 diabetics. And so we use that hemoglobin A1C level a lot. Here's the big deal about A1C though, is it doesn't shift day to day. It shifts over the course of 3 to 6 months. So if we're doing interventions to help a person with their insulin tolerance or intolerance, their insulin intolerant, and we start doing some medical interventions to try and shift that hemoglobin A1C, this is not something that's going to be shifted within one week or even a day. It's going to be 3 to 6 months of that intervention treatment. So we're in it for the long haul when we're trying to shift the A1C. Speaking of A1C, okay, here we go. I forgot to look ahead, so gave you a little bit of a talk about A1C in the last slide, so let's talk about a little bit more of this one too. So it reflects glucose levels over the past 2 or 3 months, but it can take 3 to 6 months for the interventions to work, just to let you know. So glucose A1C, glycosylated hemoglobin A1C, is how the glucose is attaching to the hemoglobin molecule. And so when you have higher blood glucoses, more of your hemoglobin is going to have glucose attached to it, therefore the higher the A1C level. It's used to diagnose. As I said on the last slide, it's used to monitor responses to therapy And it also is used as a screening tool with people who have prediabetes. Our goal range is less than 6.5 to 7, depending upon your endocrine specialist. When it's less than 6.5 to 7, it reduces complications. So, and then in case if you were just wondering, like, interestingly enough, how glucose itself is related to the hemoglobin A1C level, you can do some math and there's the formula. There's also a few different studies listed here too. So we can check fructosamine. Fructose is another form of energy that the cells can use. Fructosamine is a hormone that acts on fructose, and it will reflect glycemia in previous 1 to 3 weeks. It might be a little bit more sensitive than the hemoglobin A1C because it's only 1 to 3 weeks, right? 1 to 3 weeks versus 2 or 3 months. It is used for hemoglobinopathies. I said that without tripping. Hemoglobinopathies and or short-term. I forgot to share my screen. Oh, bookers. Let's just stop recording.